we present a technique of arthroscopic reconstruction of the posteroinferior tibiofibular ligament. The authors disclose no conflicts of interest. After creating posterior portals to the ankle joint, following the method of Van Dyke, the PTFL insertion is identified, and the damage to both its superficial and deep parts is assessed. Subsequently, through the discontinuity in the ligament, the arthroscope is advanced into the talocrural joint to examine for any intra-articular lesions. Next, debridement of the scar tissue is recommended. In cases of chronic lesions, more extensive tissue excision may be necessary. In our case, as the lesion was acute, we aim to minimize tissue removal. The anchor insertion point is selected at the midpoint of the native fibular PTFL insertion. Then an incision is made using a suture anchor guide, allowing access to the fibula behind the ligamentous tissue. Through the ligament, a canal for the anchor is pre-drilled using a drill with a slightly smaller diameter than that of the anchor. A 3.5 mm titanium suture anchor is then inserted into the fibular canal, ensuring it is fully embedded, with the anchor's sutures extending from the surgical wounds. The anchor placement is checked. It should be fully immersed into the tibial canal. The portals are switched again. At this stage, the Volkmann tubercle is visualized, and a canal is drilled in its center. The drill in the canella is inserted from the posterolateral portal. The sutureless anchor is threaded with sutures from the previously implanted anchor in the fibular insertion. The correction and adjustment of syndesmotic diastasis occur at this point, ensuring the appropriate tension for fixation. This is achieved by proximalization of the ligament to the Volkmann tubercle. This maneuver should be performed with foot in neutral position. Once adjusted, the anchor is secured in the Volkmann tubercle canal with a few careful mallet blows. The suture should run diagonally, replicating the anatomical direction of the superficial PITFL fibers. Care should be taken to avoid excessive oblique inclination, which could expose the reconstruction to greater shear forces. Fixation is then assessed by checking tibiofibular stability to ensure that there is no excessive fibular subluxation. At this stage, the tension of the reconstruction is assessed. We recommend to perform this maneuver by poking the reconstruction with the probe. Next, the anchor's placement is checked if they are fully immersed into the canals. Once the fixation is satisfactory, the loose ends of the sutures are cut, and the surgery has come to an end. We would like to thank you for watching our technique video.